Austin McCoy and Christy Chartley are our advisors for the Tulsa campus, and Jennifer Dell and Charlotte Kendrick are the advisors for the OU Social Work Student Association Norman campus. If you are a social work student at OU and interested in joining the OU Social Work Student Association, please reach out to any of the advisors on your campus. I want to take a second to thank the amazing students, staff, and faculty at the University of Oklahoma and in Henry Zarro's School of Social Work for their hard work and dedication in planning, organizing, and facilitating these sessions during our professional development week. Just a few little housekeeping items before we go ahead and get started. We are recording today. Once the session is completed, the recording will be uploaded to our YouTube channel and available for everyone. CEUs will be offered throughout the week. This is our last day, so please check the schedule to learn which sessions will have CEUs. You will have the opportunity to earn up to 10 CEUs. After each eligible CEU session, we will provide a link for registering for the CEUs. This session is one of those included for CEU, so I will go ahead and drop that link in the chat at the end of it.
Community-based interventions for suicide prevention. I was like, what is this one today?
Okay, sorry, if everybody can mute themselves real quick. Attendance at our Social Work Student Association Professional Development Week is free for students. And then we suggested a $10 donation for professionals. Your donation will be used in one or more of the following ways: student awards, general enrichment funds, and general scholarship funds. I will also link the donation link in the chat. And please list your full name in each Zoom session to verify the CEUs. And so now for our speaker, Heidi Pham is the Community Engagement and Partnerships Coordinator for the Northeast Oklahoma Veteran Healthcare System under the U.S. Department of Veterans Affairs, where she is dedicated to implementing community-based suicide prevention, intervention, and postvention efforts for local veterans and their greater communities. A licensed clinical social worker, Heidi obtained her master's of social work from the University of Oklahoma and proudly stepped into the role of field instructor to help guide new social work students into the field. She is passionate about suicide prevention, social justice, and culturally responsive care. Heidi previously served as the clinical assessment coordinator for the Tulsa County Juvenile Bureau, where she helped advance mental health care for the justice-involved youth and their families. Thank you, Heidi.
Hello, everyone, and thank you, Alyssa, for that introduction. I'm excited to be back talking at Professional Development Day. Like Alyssa said, I previously worked in juvenile justice, so if you heard me speak last year, it was a way different topic than this year. And we're going to spend a lot of time talking about, a difficult topic when we talk about suicide prevention. But the community-based intervention part, we'll talk about the public health model for suicide prevention and sort of, how can we reach more individuals when we're trying to prevent suicide. So let me share my screen here. Okay, are you guys able to see that? Okay. All right, so before we begin, I just wanted to highlight self-care for the social worker. Like I said, this is a difficult topic. It's a topic that, impacts a lot of people in this room. And so if you feel the need to take a break, absolutely do that. If you need to step away, you need to set a boundary, and maybe this is not a good time for you to listen to this. That's fine as well. And of course, I want to encourage everyone to ask for support if you need it. So just an overview of what we're going to talk about today. We're going to review current data related to suicide, discuss the public health model for suicide prevention, go over community-based interventions for suicide prevention, and just highlight the role of social workers within community practice. Suicide affects people from all walks of life. This is the most up-to-date verified data from the CDC. So this came from 2020. Nearly 46,000 people died by suicide in 2020. One death every 11 minutes is what that equates to. And then in the survey that they put out, they found that 12.2 million people seriously thought about suicide, 3.2 million made a plan for suicide, and 1.2 million attempted suicide that year. And so I just wanted to highlight that suicide is, it's a big issue, and it affects people from all walks of life. And, working in social work, it's likely that the majority of people in this room have been personally impacted by suicide in some way. And my approach, when doing suicide prevention work, sort of how we look at trauma and how we look at ACEs is, when you're working with clients, we sort of assume that they've likely experienced trauma. And so when working in suicide prevention, I always try to keep in my mind that, this individual in front of me may have been personally impacted by suicide. So populations at increased risk for suicide, adults over the age of 45. 80% of all deaths by suicide in the US are among men and women ages 45 to 54. And actually men ages 85 plus have the highest rate of suicide of any group in the country. Also, racial and ethnic minority subgroups, American Indian and Alaskan Native individuals have the highest rate of suicide as far as racial and ethnic minorities, but we also have elevated rates for Black and Asian individuals as well. Veterans, LGBTQ plus individuals, those living in rural areas, youth and young adults, as well as attempt and loss survivors. So going through some national trends and also talking about the impact of the pandemic. So looking at historical data when it comes to suicide mortality, the overall suicide rate since 2000 is 30% higher now. We did have, a decrease in rates in 2019 and 2020, but overall the trend has just increased exponentially. Between 2014 and 2019, the suicide rate increased by 30% for Black individuals and 16% for Asian or Pacific Islander individuals. And we'll talk a little bit more about what factors might be influencing that. COVID-19 so far with the suicide data is showing that so far the numbers are remaining stable and we haven't seen a significant increase as far as suicide. But, as we know, we are in a mental health crisis with this pandemic. And so we have to also acknowledge that historically, when it comes to, a large disaster or a large impact like this, that suicide rates tend to be stable or even decline, but they typically rise afterwards as the longer term impacts unfold. So we really need to keep that in mind as we navigate, mental health through this pandemic, that, even though the numbers seem okay now, we need to be preventative. So what is behind the rise in suicide rates? Suicide is a complex issue. There's no clear-cut answer and there's no, one single reason. But as far as the data, we know that we have improvements in reporting regarding mortality. And this next bullet I really want to highlight as far as the information that's coming out about Black and Asian individuals, that increased environments of stress, impact suicide, economical and political and social stressors. Impact of generational and historical trauma, also increased access to lethal means in this country. Technology and how that's opened avenues for bullying that we haven't seen, previously before cell phones, and as well as unsafe media reporting and vicarious trauma. It's only been within, the last decade or so that we've really put a focus on, what are we doing when it comes to, reporting in the media and news. So Oklahoma specifically, Oklahoma currently ranks 6th in the nation for suicide mortality with a death rate of 21.9 per every 100,000 Oklahomans. And unfortunately, Oklahoma is always at the top of the list for, a lot of things, and suicide happens to be one of them. Suicide is the 8th leading cause of death in the state. And then we looked at that 30% increase nationally. In Oklahoma, the suicide mortality has increased 62% since 2006. So that's more than double the national trend. And this right here comes from the CDC, just a visual overview of suicide mortality. As we can see, as far as regionally, Oklahoma is not performing well. I think a lot of people look at this map and they're really surprised to see how many of those southern states are doing way better than Oklahoma. And so that just gives you a little context for how we're doing. So what factors may be contributing to increased rates of suicide in Oklahoma? Our geographic location does have something to do with it. We are on tribal lands and we have, a significant American Indian population. We also have a lot of rural areas in Oklahoma. And, as we know, if you're in a rural area, it's harder to get to your resources, and there's just lack of resources in general. There's a lot of access to lethal means. We are a constitutional carry state. And also we have, a lot more access to with, medical marijuana. We have an opioid issue. There's a lot of access to lethal means in the state. And something else I want to highlight is, Bible Belt culture. A lot of the things that we're talking about today is still, not talked about, or people are uncomfortable talking about. I've heard, that doesn't happen around here. Oh, we shouldn't talk about that. Suicide's very taboo. Mental health problems are taboo. So as a state, we're not talking about these things. Our military and veteran population. Oops. Okay, so per capita, Oklahoma has the 15th highest rate of military enlistment in the nation. So we do have a large number of service members and veterans. And also we need to talk about our political climate and resource allocation. Is our money going to mental health and education? Not enough of it. So the public health model for suicide prevention, I just hit everyone in this room with very difficult statistics and, some really concerning things about what's going in our state. And so I need to build a little hope for you guys. So the public health model for suicide prevention, this is something that's been adopted within the recent years. As we saw, suicide rates in the nation peaked in 2018. And that's sort of when, we sort of went full force with this public health model. So we know that suicide is preventable. Everyone can help prevent suicide by learning the warning signs, promoting prevention and resilience, and committing to social change. And so this really highlights this public health model, that prevention efforts that target not just individuals, but their families and communities through a multidisciplinary public health approach are most effective in preventing suicide. We also know that 90% of people who survive a suicide attempt do not go on to die by suicide. So some of the things that we're going to talk about today, if we can collaborate ahead of time to help someone survive a suicidal crisis, we have likely prevented suicide for the rest of their lives. So what is public health? Public health is utilizing a population approach to improve health on a large scale. Key components of public health are universal prevention that targets large groups or populations of people versus just focusing on individuals. Proactive versus reactive, so preventing the suicidal behavior before it occurs through addressing risk and protective factors. There's a lot of focus on research, data, and science. And, I always encourage as new data comes out to, inform yourselves about that. I was really shocked to hear about the new trends as far as, our racial and ethnic minorities. And that's stuff that's ever changing. Multidisciplinary collaboration to bring together different perspectives to strengthen solutions for diverse communities. I'm going to talk a lot about multidisciplinary collaboration today as far as, how we can do community-based work. So at the VA, we've adopted a public health strategy for suicide prevention. And this is just a little visual that can, tie everything together. That middle circle there, that clinically based individual focus, for many, many, many years, that's all that we really focused on when it came to suicide prevention. Is we focused on, having the right EVPs, having the right therapies whenever people come to the door and access care. But what we learned, when looking at data is, as far as veterans, 2/3 of veterans who died by suicide were not engaged in VA care. So we were missing such a huge population in helping them, but they're in the community. And so what are we doing to sort of reach them? And so that community-based suicide prevention approach came from that public health model that we're starting to combine these community interventions with those clinical interventions. And so I'm the community engagement and partnership coordinator for Northeast Oklahoma. I serve 27 counties, and I have a lot of rural counties. And we have another CEPC based out of Oklahoma City. So the community-based prevention strategies that I focus on in my position is developing community partnerships, building community coalitions, connecting those rural areas with resources, doing outreach and education, gatekeeper training, as well as supporting the governor's and mayor's challenges for suicide prevention. And that's just state-driven suicide prevention planning and trying to get things, in policy and legislature. So that's what I do. And then we have, our clinical piece inside our hospitals and clinics that they're focused on the evidence-based psychotherapies and interventions. And something within the recent years with the pandemic is making sure that we can deliver those through telehealth as well as in person. And so some of these are, the therapies that we utilize. And, if you are planning to be a clinician that works with, suicide prevention, you might look into getting trained and certified in one of these. So community engagement and partnerships program, these are just some of the anticipated outcomes that the VA hopes to achieve with having this public health model and targeting the community. Some short-term objectives is enhanced prevention networks, increased reach and adoption of community-based interventions for suicide prevention. So, we're not just focused on veterans here. We're focused on suicide prevention in general and, helping the community do better and improve our service delivery for our community. Intermediate objectives for that, increased formal help seeking. We want to see more people accessing care, accessing resources. We want to see improved collaboration among service providers. And, the overall population impact we hope to achieve is reduce suicide deaths and attempts, reduce all-cause mortality, and reduce suicidal ideation. So public health strategies for suicide prevention. This will go into specifics of, the work that I do and the work that I hope you all take with you, as you go back to your practicum sites and as you guys graduate and move into the field, hopefully, you'll be at an organization where you guys are already doing this, or you can bring this to them. So building community coalitions. Why? A coalition is a group of individuals and or organizations with a common interest who agree to work together towards a common goal. So bringing together, the meeting of the minds. We have so many resources, especially in Tulsa. We have so many mental health agencies, and, as far as serving the community and providing the best care, working together is the best way that we can do that. And that's what I love about the work that I'm doing, is there's that focus on, we don't care where someone's accessing care. We just want to make sure that they're getting the care that they need. And so setting aside some of those things like turf issues and, concerns about billing and productivity, we need to set those aside to be able to have the impact that, we hope to achieve, that we advertise that we're doing. And so we want to impact community health by bringing together community members to jointly share ideas, resources, and goals. And within a coalition, you also have that shared responsibility and accountability. Not everything is just falling on one person or one organization's shoulders. Research demonstrates that communities with strong partnerships and collaboration within their health systems and service agencies have better health outcomes with their population. So who is at the table when we're doing coalition building? We want to utilize research to identify who our stakeholders are, who our change makers and policymakers are. So the community stakeholder is any group or individual who can affect or is affected by the achievement of the coalition's objectives. So traditionally, this may look like community members and leaders. And I highlighted here that you want them representative of the target population or issue. So if I'm working on a suicide prevention coalition for veterans, I need veterans in the room because we want, our population served to have a voice. Community mental health agencies and healthcare organizations, government and public safety. So that would include like DHS, law enforcement, advocacy groups and service organizations, as well as your academic institutions. And then I have Shocked Pikachu over here on the non-traditional side that I think a lot of people have been really surprised by whenever I talk about what I'm doing for outreach or, who I want at the table at some of these coalitions, because I'm talking to gun shop owners and firearms dealers and liquor store owners, getting pharmacies, bar shop owners to, be there. And people ask, like, why would you do that? What do they have to do with mental health? Well, a lot of those places have to do with, they might be the support network for someone, or they might be where that person gets access to lethal means. And so you want them at the table to sort of, share that vision, share that goal. We're not trying to take your business away. We want to save lives. So also think about your faith-based communities and leaders, media organizations and outlets. I do have to acknowledge we are in the age of the influencer. And, some of the work that I've done, those influencers have really been key to getting some messages out there. So, don't discount social media and its role in suicide prevention or mental health awareness. So effective community-based suicide prevention, you want to be having all of your team members, once you develop that coalition, at the table, working towards all of these things. You want to develop that shared mission, do a needs assessment on your community, find out what resources you have, what you're missing, what you can do better, and start to formulate some of those goals and developing an action plan. Keeping that organizational capacity, planning and implementation, and everyone working together to evaluate how you're doing, what you can do better, as well as how to sustain what you are doing. And that's, I see some burnout in coalitions sometimes that, they stop meeting or things get overwhelming. And so you really have to work on that sustainability piece and remember your why and why you are there and the work that you guys want to do. So what needs should you focus on? This is CDC's Preventing Suicide Technical Assistance Package that they put out. And this came out in 2017, but still is sort of like the standard for public health when it comes to suicide prevention. And so if you're interested in doing this work, definitely give this a read. But their main focuses for effective suicide prevention in the community is strengthening economic support, strengthening access and delivery of suicide care, creating protective environments and promoting connectedness in the community, teaching coping and problem-solving skills, identify and supporting people at risk, as well as lessen harm and prevent future risk. So the next few slides, I'm going to talk about, how do we achieve those things? What are avenues that you can go about to meet some of those goals? And I called these strategies 101 because it's, stuff that we are already doing and we know to do, but are we actually, doing enough of it is what I ask. So the first one I want to talk about is increased screening for suicide risk. Increasing screening practices help us identify vulnerable individuals and connect them to supports sooner. I think a survey of, it was healthcare systems about suicide screening. That survey found that the majority of healthcare organizations in our country were not actually asking about suicide, or they weren't asking about suicide effectively. And that's why I highlight here, encourage the adoption of a universal evidence-based suicide screening tool amongst the community or coalition. I know at the last organization I was at, we did, there was a big push for evidence-based suicide risk screening, because going over some of the, tools that we were using or the questions we were asking, they were completely dated. Using problematic language. If on an intake form, if you're filling it out and it says, do you want to commit suicide? That's super dated and that's problematic, and it's not an effective way to ask someone if they're experiencing suicidal ideation. So I have on here the Columbia Suicide Severity Rating Scale. It's widely utilized. We have that at the VA, and a lot of our partners are using it. If you're not familiar with that tool, I believe next Friday Parkside is doing an informational CEU on it virtually, and I do have the details of that later. So if you want to learn more about that, check them out and kind of learn the ins and outs of it. So other strategies, gatekeeper training. These trainings teach people in the community to identify individuals who are showing warning signs of suicide risk and help people get into the services that they need. And the good thing about this is gatekeepers can be anyone. The training provides guidelines for effective and safe messaging regarding suicide, effective evidence-based ways to ask someone about suicide and talk to them about suicide, which common ones, QPR, I think, there's regular QPR trainings at OU anyways. The VA has Operation Save, there's Assist, as well as Campus Connect that's commonly utilized on universities. And these are those basic level gatekeeper trainings, how to ask someone about suicide. And I know in this room, we have social workers that are up and coming. And so, yeah, we know more. We're supposed to know more than the average person because of our education and background. But I do suggest, if you haven't gone to a gatekeeper training, please go, because we also need to understand what our community knows and what we are also asking our community to do. And the third strategy I'm going to talk about is lethal means safety. Lethal means safety is an intentional voluntary practice to reduce one's suicide by limiting access to lethal means. And so if you're working with someone, do you feel comfortable counseling about lethal means safety? Have you received training in lethal means safety? I know this is something that, when I went through the program, I didn't learn this, and I had to seek training opportunities for it because I didn't feel comfortable talking to someone about lethal means safety. So lethal means might look like safe storage of firearms, medication, and other potentially lethal means, safety and crisis planning. We also talk about reducing access to alcohol or illicit substances that may lead to impulsive decision making. So educating individuals, families, and communities on lethal means safety and counseling can help lives. This is something that is intended to be collaborative when you're working with a client, because it can be a difficult conversation to have. And, there can be a lot of defensiveness that comes up. And so having, their voice in it, having their family there to support them, that's always helpful when you're talking to someone about, reducing their access to lethal means. The VA does offer free lethal means safety training, as well as resources for safe storage, such as gun locks and pillboxes. You don't have to be, working with veterans, and you don't have to be a veteran to access this resource. So, if you're interested in getting more training, let me know. If you want to get gun locks, pillboxes, anything like that, let me know. And there is also a training online. It's a CALM training, counseling on access to lethal means. I believe that is still free online training. So why is lethal means safety important? The focus of it is increasing the time and distance between someone with suicidal intent and lethal means. That can greatly reduce risk, and that can save a life. And for a lot of people, especially in the state of Oklahoma, there's a lot of resistance to taking away a firearm. And lethal means counseling, it's not necessarily saying, we're going to take these away. It's, well, what can we do to sort of disrupt, that thinking process and increase that time so that there is an opportunity for intervention. So it's not saying that we're going to take it away, or, your family member is going to take it. It's talking about what can we do to give you time to process through that suicidal crisis. So most suicidal crises are brief, from time of decision to action. And so we're seeing here that the majority of suicide attempts, the action happens within an hour. And so the point of lethal means safety is we want to build in some time there to sort of disrupt that thinking pattern whenever it comes time to act. So if you have someone who, their means would be a firearm, and you have that safely stored away, or you have it locked, you have ammunition stored separately or off-site, those are different ways, even if they are intent on keeping it in the house, that maybe you have disrupted that time enough that, they can survive that suicidal crisis. So just general tips for working in suicide prevention. Safe messaging is so important. We've had a lot of research come out about just our language and how we talk about suicide. We want to be trauma informed. We want to be respectful. So first and foremost, the language that we use is died by suicide. We're very direct and objective. They killed him or herself or themselves. We want to avoid the problematic terms such as committed suicide or completed suicide. Those words associate suicide with crime or sin, or paint it as a desired outcome. We want to speak neutrally and factually. Suicide, death, an attempt to end his or her life, non-fatal self-injury. Whenever we talk about completed suicide or failed or unsuccessful suicide attempt, it makes it seem like suicide was a desired or positive outcome. We want to use non-sensational and objective terms when we talk about rates of suicide. We want to avoid overgeneralizations, like suicide epidemics, skyrocketing rates. That increases stigma and fear. And we also want to acknowledge loss. And, when we talk about a suicide, keep the information about the person general. We want to report on the suicide as a public health issue. We don't want to go into specifics and just describing specific details or even utilizing romantic language whenever we talk about suicide. And I have a quote in there, picturesque storytale village. And that was a detail utilized in a very now famous article about Anthony Bourdain's death. Is they really romanticize the scenery around it. And whenever you use that kind of language, it can contribute to suicide contagion. And so we definitely want to be factual, we want to be objective, and we don't want to put any triggers in the language that we use. So working in suicide prevention, other tips, think outside the box. I talked about those, gun shops and bars and firearms dealers. That sounds like a little weird for someone working in mental health or like a social worker to be really involved in those areas. But when it comes to suicide prevention, you have to meet your population where they're at. Where do they spend their free time? What activities are they doing? Incorporate non-traditional approaches to education, prevention, and intervention. This weekend actually is the gun show at the expo, which Tulsa has the biggest gun show in the world. And I will be there. And I will be there passing out gun locks, to people who are willing to take them. And, anyone that comes up that might want to access some crisis resources, I'm going to be there. I was also at the Broken Arrow St. Patrick's celebration. And we were there giving out koozies with crisis line information, suicide prevention hotline information. What are ways to get that information out there where you might find someone that's vulnerable? Also, utilize your partnerships within your community to obtain buy-in, break down barriers with specific populations. So for me, part of getting into the gun shops, I can't just come in with my VA badge and say I'm with the suicide prevention team, at the VA to a gun shop owner. Immediately, the look on their faces is, they don't want me there. But if I come in there, with a veteran who's able to communicate hey, I speak your language, I'm on your side, and this is important to me, that conversation might happen differently if you can get that buy-in. So create a network of support for those not engaged in care, train gatekeepers within families, schools, faith institutions, and local businesses. So, a lot of people are going to be really resistant to asking for help, but part of the goal of suicide prevention is, getting the community to be able to start to recognize those risk and warning signs that even if a person is afraid to ask for help, that maybe someone will identify something's going on and be able to talk to them about it. So the social work role, suicide prevention is everyone's business. All the work that you all are doing and will do in the future is working towards suicide prevention. And so, talking about the role here, you guys are already doing it. And this conversation is just about, how can we do more of it and how can we do it better? So if you want to get more involved, continue to seek training opportunities to enhance your understanding of suicide, I have there listed, some of the evidence-based therapies and interventions that have been shown to be effective for working with suicidal patients or clients. Join or start a suicide prevention coalition in your organization or community. We do have, some that have already started up locally. We have part of my job is to try to get more of that across the state. If you want to join or start a suicide prevention coalition and get in touch, let me know. Become a gatekeeper, go through that training. And, and just at the very least, we just want to reduce the stigma by talking about suicide. So here are some upcoming learning events. Like I said, Parkside is doing the Columbia Protocol overview next Friday. The VA also has an informational session about their new crisis response program for veterans. So if you're interested in that, I have that information. And I do have all the links in this that maybe if I copy and paste this, it'll just go through the chat. There is the Zero Suicide Summit coming up. That's an all-day event.
Mm-mm.
And then we
No, if I
have
come back from a bit,
we have Parkside
patient
doing
may
another
wanna-
session on suicidology. And if you're looking for, more information on military culture, gatekeeper training, one of our veteran service organizations does a wonderful job of that, Eagle Ops. They have some events coming up in the summer, and they do these trainings every quarter. And so now I will just open it up for discussion and questions. Again, if you want to connect, my information is there.
Thank you, Heidi. If anybody has any questions, if you want to put them in the chat, or if you want to unmute yourself, whatever way works best for you guys. And I will link the CEUs in the chat.
I'll probably just email you. There was some information that I missed that I want to get. So thank you for this, Heidi. It's very, very informative.
Yeah, absolutely. Reach out. And that phone number there is actually, a cell phone. So you can even text me. I do get a lot of scam likely. So if I don't pick up, I will call you back if you leave a message.
Heidi, I might have missed this, but are you making the slides available? Do you want to send those to me?
Yeah, I
Or
can
just
send
the
it
recording?
out for you guys. And Alyssa, you can get that information. Let me see if I can get that training information at least through here.